be in the second half of the year, bimotrizanol. And what's nice about it, it's photostable. It basically has broad spectrum. Here's the coverage, and you can see it's got UVA, UVB, and really good coverage with it. And second thing that's been hot, of course, we know that nicotinamide does work in terms of lowering risk of non-melanoma skin cancer. This was a larger study that was done, over 33,000 patients at the VA for this. And what was interesting, of course, the patients who used nicotinamide did better, but what made this study different, the earlier you started the nicotinamide, the better you did. So you did better after, if you started after a first skin cancer, better than after a second, better than after the third, better than after the fourth, as you can see from these graphs here. Okay, non-melanoma skin cancer. Squamous cell carcinoma, the incidence of squamous cell is still rising. This is a Denmark list, but we can see this anywhere in the world. This is an interesting paper that showed if you have a report that says squamous cell carcinoma extending to the base, and squamous cell in situ extending to the base, take it seriously, because you can see 1 out of 12 in this series had an invasive component. So take that seriously when you see it. And then we know there's staging systems that are available for squamous cell carcinoma. The classic one is the AJCC8, which is basically looks at several risk factors. We have the BWH system, which looks as a point system for squamous cell carcinoma. But the problem is with these two major systems, there's only about a 3/4 concordance agreement of what's a high-risk case and what isn't. So they're a little different in their results. So how can we do better? We now have the 40 GEP test, which uses gene expression profiling. And basically, this is for high-risk squamous cells. Not for, they have to have at least one of these risk factors. It's not for a simple early squamous cell. But the beauty of this is that you can integrate it into your clinical practice. I'll put this up for a second, get the QR code. This paper has all the information of how to integrate it into your practice that we published in JDD for this. Okay. What does this test do? Well, it divides these squamous cells into 3 levels of risk: low risk, moderate risk, and high risk. And in fact, about 1 out of 18 of the patients in the series were in that high-risk group. So it identified the high-risk subset of patients to focus our attention on to do this. And this is looking at a bunch of ways so you can integrate it with the other old staging systems to be synergistic and get even a better assessment of risk for these patients to do it. Now, if you look at the BWH-T1 patients, so all early patients, you can see from that red line on the bottom that you've identified a high-risk subset and the low-risk group to focus on, which is kind of interesting to do this. The other thing is, if you want to decide which patients need adjuvant radiation therapy, it turns out that the 1s and the 2As really didn't benefit, but the ones that were 2Bs did significantly benefit, so it's a way to really triage your patients appropriately for that. Cemiplimab, this is the paper that came out in the New England Journal at the end of last year against placebo, did well for advanced squamous cell carcinoma, so something to consider. And the new kid on the block is cosabelimab, which is a PD-L1, and basically the beauty of this one is that it had, in the series, had no grade 4 or greater AEs in terms of the study, so a little less adverse events for it. We'll be hearing more about that in the future too. Basal cell carcinoma, the rates are going up in the US. You can see here's data from a recent paper. Now, this was a paper that was in JAMA, not JAMA Derm, but JAMA about a month ago, looking at recurrence rates for various treatments of basal cells and squamous cells. I'm not sure I agree with these recurrence rates. Hopefully, I'm a little better than this. But what was interesting was another paper came out looking at curettage alone. So I've combined these, and you can see that curettage alone did almost as good as the other treatments that are there for this. We did a paper 20 years ago looking at curettage followed by imiquimod. It was a short series, myself and Abel Torres, and we had 57 patients, no recurrences at 1 year with good cosmetic results. Well, this paper came out in JAD International with a bigger series of about 600 patients with 10-year follow-up and only a 2.5% recurrence rate. So something to consider. It was curettage, wait a week, 6 weeks of weekdays on, weekdays off for imiquimod treatment for this. Another paper that just came out from Joel Schlesinger's group looking at PDT for superficial basal cells with, you can see, about an 83% cure rate for these patients. Now, we know hedgehog inhibitors work, but one of the problems is the discontinuation rates from the side effects. So this paper was published by Dr. Lebwall in Dermatologic Therapy just recently, and the interesting part of this was that the Sony patients had fewer adverse effects than the Vismo patients, so therefore they stayed on longer and more compliance for this. And then finally, this paper came out about if you fail hedgehog inhibitors, you can use cemiplimab for the advanced basal cells for this, which is a good study. And you can see the 5-year, 50% greater than 3-year survival for metastatic basal cell for the hedgehog inhibitor failures. Merkel cell carcinoma. Obviously, pembrolizumab is now considered the treatment for advanced Merkel cell, and you can see about a 50%, at least 2-year survival with metastatic Merkel cell for this. What's more interesting is this paper that just came out that shows you can now have polyomavirus antibodies. And if you look at the titers and the trends in the titers, if they're negative or falling, the patients do well. If they're rising, that's a sign you should be following the patients more closely. So again, take a look at this paper if you can. It's really a good one. Melanoma. At the current rates, 1 in 40 Americans will get an invasive melanoma during their lifetime, and you can see how the incidence has risen dramatically for this. If you add to the 112,000 estimated cases this year in the U.S., another 122,000 in situ cases, do all the math, put it all together, the risk of an American getting any kind of melanoma in 2026 is about 1 in 19. So again, a significant public health problem. And if you look overall, melanoma is now the 4th most common cancer in the United States in men and the 5th most common cancer in the United States in women. So again, a significant public health problem. Now, it's not just an American problem. Worldwide, melanoma incidence is increasing. It's estimated it'll be increasing between now and 2040 by up to 50% over the current cases that we see worldwide to do. Now, this is the death rates in the U.S. from melanoma, and you see from 2006 to 2016, it went up. You see it drop because we'll talk about the effect of the new advanced melanoma treatments that we have, but we basically just shifted the curve down because now the rates are crawling back up again too. So we have a lot to do as dermatologists for this. And do we make a difference in melanoma mortality? That's what we really want to do in dermatology. Well, this is one of my former fellows, Dr. Shah, who published this in JAD, looking at the distribution of dermatologists in the United States. And you can see it's definitely non-homogeneous. There's concentrations in various areas. So my other former fellow, Dr. Burstein, did a paper where he looked at the density of dermatologists against the melanoma mortality rates in each of those areas. And what he found was kind of interesting, which was the higher the density of dermatologists, the lower the mortality. So it may be due to access, whatever the reason, we clearly are making a difference. You all can feel good about yourself now, right? We're doing something good here from this paper to do. Okay, diagnosis. This paper was done 50 years ago by my mentor, Alfred Koff, at NYU, and the diagnostic accuracy of dermatologists at that time was about 2/3 correct. We published, it's 40 years ago now, we published the ABCDs of melanoma. This is the original article in CA between myself and Bob and Al Koff. And we just published this article last month in CA. You know you're getting old when they have you do 40-year retrospectives, right? But talking about what's new in this area, and again, I have the QR code if you have a chance to read it. It's a good article, an update on diagnosis of melanoma. And probably the biggest thing that we're seeing with this is the impact of AI on diagnosis. Now, why is AI important? AI enables us to conceive of other variables we might not think about and integrate those variables into a diagnostic kind of thing. There are a lot of devices coming out with this. It's just one of them, the Nevisense device, but it uses an AI-based algorithm to try to augment the accuracy of diagnosis. So is AI going to replace dermatologists? Well, with radiology, I thought they'd all get replaced, and in fact, they haven't. They've used AI to be a tool to be better at what they do, and we're seeing the same data from dermatology. This is a paper that came out showing that the AI had slightly better sensitivity, the derms had slightly better specificity, but the best was the combination of the two of them, using AI as a tool to make us all better. We'll be seeing more of that in the future, too. Prognosis. This is Alexander Breslow's original paper on thickness of melanoma. He was actually one of my professors in medical school, and you can see he found 0.75 millimeters of thickness because none of his patients less than that had any recurrences. We published a paper in the New England Journal when I was a resident. We found 0.85. Whatever it is, there's an early break point, clearly, in thickness. How do we do better than that? Well, that's probably with GEP testing, and that's going to make a big difference. This is data from the SEER database. So I think you know SEER takes about half of the U.S. population and collects it for cancer. And what they did is they looked at over 3,000 cases that were in the SEER database that had the testing done. So not from the company, an independent database. You see that red line on the bottom? Those are the high-risk cases. The black line was the average. So the bottom line is the test clearly broke people up into a low-risk, medium-risk, and high-risk subset. Now, what was also interesting, if you did a multivariate analysis on the data, you could see the results of the GEP test were more statistically significant than thickness alone, both for a melanoma-specific survival and overall survival for it. And also, interestingly enough, the patients who were tested in the group did better than the ones who weren't tested as the controls. Now, it's obviously not a therapeutic test, but the reason was they were followed more closely, and you can see the difference that their melanomas, if they had metastatic disease, were detected earlier and they could be moved to treatment earlier for that. We could use genomics in looking at sentinel node biopsy and selecting patients. These are the NCCN recommendations for this. Less than 5% don't do it, more than 10% do it. Between that, talk to the patient. But look at this, if you just use AJCC8, you don't get any patients less than the 5% chance of having a positive node, while with the GEP testing, you can divide the patients into less than 5, greater than 10, or in the middle to do it. Now, what's interesting is about 5 out of 6 patients who have sentinel node biopsies done are negative. The overwhelming majority are negative. Why is that important? Because even though they have a lower probability of dying, more people die who are sentinel node negative than sentinel node positive, because there's just so many more of them, not percentage-wise, but absolute number-wise. So even in the sentinel node negative patients, we have to identify that high-risk subset, and the test does that. You can see this was 6,000 patients in a series. Look at the red line on the bottom. Again, you can identify the high-risk subset and the sentinel node negative patients to follow them more closely and manage appropriately. Okay, management. Wide local excision before the sentinel node biopsy. It turns out it doesn't matter. You're not distorting the stuff for this. Melanoma in situ, the original margins came from the 5mm surgical margin area, and in fact, that was only by experience, not by data. Other papers have come out suggesting that, in fact, you need to go wider for this. You have to take melanoma in situ seriously. This is a paper that just came out in JAD recently that said that for the head and neck, maybe you need 15mm margins on these patients. And then finally, finishing with advanced disease, we all know about neoadjuvant therapy, basically treating before the patient, and adjuvant therapy after the treating, the surgical resection. Bottom line here is that the combination does better than just adjuvant therapy alone. Combination therapy is the hot thing in melanoma. You see the combination here is better than the 2 individual drugs. And is there a cure for melanoma? We're not quite there yet, but this paper was just in the New England Journal. If you survive 3 years, that's the first line over the left, almost everybody survived 10 years. So about 50%, 60% are surviving 3 years, but almost everybody survived out to that. So in summary, the key points, I think hedgehog inhibitors and PD-1s for advanced non-melanoma skin cancer. Prognosis can be really enhanced for both of these tumors for GEP testing. Squamous cell patients that can benefit from ART can be identified for this. AI is making an impact in diagnosis. Dermatologists were doing something good, an impact on mortality. Some patients can survive melanoma, but we as dermatologists have to stay on top of all these things so we can enhance our patient care. Thank you very much. Okay.